All right, welcome back to the Find Your Edge podcast. I'm so excited for this topic and our guest. So, we're going to jump right in. Welcome, Abby. I would love for you to introduce yourself, tell us who you are, how you got into this, tell us about your practice, and all that good stuff. So,
All
take it
right,
away.
great. Well, I'm happy to be here. Thanks for the invitation.
Yeah.
My name's Abby DeVries. I'm a family physician and have been in practice for a little over 20 years. And about 4 months ago, I started my own direct primary care practice, really focused on women in midlife, so in that kind of late 30s to early 60s range. And over the last couple of years, I've really kind of dived deep into menopause and perimenopause care, still learning as the rest of the medical community is as well, but have really tried to learn as much as I can about how to help women really thrive in this phase of life and then age strong. So I'm doing a lot of menopause hormone therapy along with all the preventive management and chronic disease management. So
That's awesome. And just a little plug, you are, for those of you who are listening in the Triangle area, you're in Chapel Hill.
yes, I'm Chapel
Yeah.
Hill. My office is in Durham. I do a lot of care virtually. I can see anybody in North Carolina, and also if people live really close to me, I'll actually do a home visit. But a
Ooh.
lot of care is done in my office in Durham. So.
Very cool. All right, so you mentioned the direct primary care model. Tell me how that's different than what we're typically used to and from something like concierge medicine.
Yeah. So direct primary care is a model that has been growing really steadily since just before COVID. And it's a membership-based primary care model where you pay a monthly fee and kind of have pretty guaranteed access same day or next day, longer visits, ability to access your physician via text or email, or a quick phone call because you're not kind of tied to that visit. The provider isn't kind of dependent on that visit for the revenue, smaller panels, and just a much more approachable aspect. You can, if you have a high deductible health plan, submit your membership fees to the HSA and get reimbursed pre-tax on that. But we typically don't bill insurance, so we're not double dipping like a concierge model where typically people will bill insurance and then pay a kind of retainer fee. So it's a one fee kind of for most services within the kind of primary care scope.
Okay, cool. That was a great explanation. So, what led you into getting deeper into understanding these women at this wonderful time of life?
Yeah. Well, as it often happens, I kind of reached that phase of life myself, but also was doing a week-long continuing education. Harvard does really great primary care training every March, and 1 hour of this, 40 plus hours of training was on menopause, and it really piqued my interest. And I realized that what I had been taught in medical school, I was in medical school when the WHI trial came out in 2001. I really kind of had not learned what the facts were, and then also there's been new data that's come out to really show the safety and real benefit potentially for hormone replacement therapy. And so I've just tried to learn everything I can, and it's kind of through podcasts and books, and there's some really great female physicians kind of leading the charge on this, and I'm happy to be on board.
That's so awesome. We'll have to get into like some of your heroes at the end here.
Yeah,
So
I have some props.
yes. Oh, so good. Okay, great. So when women are, and of course, we're speaking to a lot of endurance athletes and high performers, people who really want to do amazing things. What are some things that we need to maybe even think about before we reach this stage of life? And then as we ease into it, what are some of the things that we're looking for from a symptom perspective? Is it somebody like you who can help us understand our unique hormone profile? Like, do my hormones look the same as your hormones? Like, is it all exactly the same? Should we all be having these exact curves in various hormones? And what are some of the things that we need to look for?
Yeah, so if you're, pre-menopausal and, anywhere kind of generally younger than your late 30s, if it's the typical pattern, you should be having regular cycles unless you're doing some sort of hormone therapy that, birth control or an IUD that would make you not have a cycle. So you should be having regular cycles, and the bleeding should be manageable. And that would indicate that you're sort of having the typical rise and decline of FSH that triggers the estrogen and progesterone to cycle. And so that would be considered, normal menstrual functioning. And then, one thing that happens often with endurance athletes, as you know, has periods of amenorrhea. And that is actually really a low estrogen state and has a pretty profound effect on bone mass, for one thing. So people who've had a history of that, or celiac disease, which is a pretty common thing that as well is under-recognized as a cause of low bone mass in the future. So those would be potential things that if people have a history of that to think about, getting evaluated sooner for bone mass. And then, I'm trying to think if I don't think there's anything else really typical for athletes other than that I would caution about. But sometimes people will think, they're getting lazy or something, and really they're entering this premenopause phase and their hormones are shifting, and that really does change kind of the profile of endurance, and there is things you can do about that, so that feeling like people shouldn't just give up when they reach a certain age.
Yeah, yeah. So, are there certain symptoms that maybe we should potentially be expecting? I mean, I would assume that it varies widely,
Yeah.
woman to woman, but maybe forgetting our car keys all the time is
Hmm.
not just in our imagination.
Exactly. Yeah. So the common things in perimenopause are the brain fog or forgetfulness, like feeling like, do I have early dementia? That's a big one. The other huge one is sleep disruption, especially that kind of 2 a.m. wake up where you're up for 2 hours and kind of get into this anxiety spiral. That is classic for perimenopause, and it typically comes from a drop in progesterone. People will also note kind of mood changes, maybe being more anxious. And one thing to note is if people have a history of challenges with mental health postpartum, some of those same hormonal changes are happening in perimenopause, and they're definitely higher risk for anxiety and depression, ADHD type symptoms in the perimenopause phase as well.
So, is it when there may be some level of experience of anxiety or brain fog? Not to say that psychology and psychiatry is not a wonderful field, but would you say maybe assessing hormones might be a good first approach?
Yeah. And we don't necessarily check levels. It's more based on, what is your age? What is the kind of complex of symptoms that you have that we can sort of say, this sounds like perimenopause. It seems reasonable to try some low dose hormones before we jump to, say, an antidepressant or an ADHD medication or a big workup, um, making sure that we're kind of ruling out some other things too. Thyroid is another thing that often goes haywire in this age, anemia. The other big thing is bleeding pattern changes. So either really heavy menses or irregular, kind of longer cycles. So if you're starting to have that, then that can definitely be a sign too of perimenopause.
Okay. Um, so is there, in that case, is it like, okay, let's start on some level of progesterone, or are there any tests to understand, like, certain time? And I've also heard, oh, do your best to try to get tested the first few days after your menses, or what's up with all that?
Yeah, I mean, so your hormones do cycle throughout the month. And so a level is just that 1 hour of time that you're getting it tested. So it can be a little bit informative, especially if someone has a reason why they're not having a menstrual cycle, like they have an IUD or they've had a hysterectomy. An estradiol level can be, a little bit directional at least. We typically don't just test progesterone. And then testosterone is something maybe we could talk about later, but we do check those levels. So typically, if I see a woman who comes in saying, they're waking up, they're feeling more anxious and like a little bit more fatigue, I'll just say, well, let's just try a little progesterone. And then, if they get closer, if they're having hot flashes or more kind of menopause type symptoms, joint pain, frozen shoulder, then we'll throw on the estrogen patch. But we don't have to wait until, the periods are gone to try any of the hormones.
Okay, good to know. And then does that continue through menopause? Like, or do strategies change?
Yeah, so they can. So everyone experiences things differently. So some people will have terrible symptoms during perimenopause, and then once hormones kind of level out, they feel great again. Some people kind of sail through perimenopause and then develop really severe symptoms like hot flashes, joint pain, things like that a year or so after menopause. So everyone is a unique individual, and what dose of hormones is working for you today may not be what's going to work for you in a year or two. Typically, once you get through menopause, again, we can kind of get to a dose that's pretty steady, and I wouldn't anticipate having to tinker a lot. But during perimenopause, definitely, some people feel like they only need hormones during part of their cycle, for example. So it's really a kind of just let's try this and then let's be in touch in a week or two and let's see what's working and what's not. And that's one of the beauties of this model is that, you don't have to wait until you see the doctor again in 3 months
Yeah,
to kind of figure out what's working and what's not working. So.
definitely. I'm also thinking of the woman who might be like, okay, well, now that I'm menopausal, which I'll have to have you touch on what officially is the
Mhm.
definition of menopause. And then maybe even officially with a definition of perimenopause and
Mhm.
those types of things. That way people have some context there. But let's say they're like, okay, well, my kids are out of the house now. Whether it's related to hormonal changes or not, now I'm going to do an Ironman or I'm going to run a marathon. Or would you anticipate that changing any potential tweaks in hormones? And you may not know the answer. And, I
Yeah.
find that this is an amazing emerging field that we've just
Yeah.
kind of been ignoring for a long time. So,
Yeah. I
anyway, I asked
don't.
you a lot of questions
Yeah.
there. I have that
Yeah.
habit, so you're
Yeah.
welcome.
Well, let me just start with the last one since I
Yeah.
remember that. I have not seen or had experience with like what big lifestyle changes do for the hormone needs. I think it would be let's just wait and see. And if we need to adjust it, we absolutely can. And then as far as kind of definition, so menopause is actually one day when you have not had a period for 12 months. Now, and then you're postmenopause, but we typically talk about postmenopause as menopause. And then perimenopause is the years leading up to the actual menopause day. And that can be, 7 to 10 years. And so if the average age of menopause is around 51, that means some people experience it much earlier. So late 30s is often when perimenopause will start for women. But then, again, people can sail through into their late 40s and then suddenly, start experiencing it. So it's a big range.
What's typical age range for menopause?
So it like 51 is the average, and so it's kind of that late 40s, early 50s, and but again, then some people can still have regular cycles up into their mid 50s, and you can absolutely get pregnant in perimenopause. And so sometimes people think, well, I'm not having regular periods. There's lots of opportunity for pregnancy, so you want to make sure that you've got that covered as well.
Okay, cool. So I would anticipate that, especially you mentioned bone density, that exercise is still important in
Absolutely.
perimenopause, menopause
Yeah.
timeframe.
Yep. So it's like hormones plus exercise is
Mhm.
in obviously healthy diet as well. But yeah, so the bone mass starts to decline pretty rapidly in the year or two leading up to menopause, which again, you don't know when that is until in retrospect. And so that's another reason we don't say you need to wait until you get through menopause to start hormones because you're adding that protection in right when you probably most need it if you start when you develop symptoms. And then the strength training is huge for maintaining bone mass. And so you want to do progressive overload. And this goes for your, runners and stuff like that too. They really need to incorporate the strength training. It's critical.
Yes, absolutely. So what I've seen is people who may have been used to like heavy volume or heavy loads then have to tweak to reduce their overall load of running or whatever endurance exercise they're doing and make sure they're prioritizing that strength training.
Yeah.
So, okay,
Yeah.
that
And
sounds
not
good.
the pink 3 pound ones, but you need to be
Oh my goodness.
progressively adding. Yeah.
Yes, you just touched on a massive nerve of mine. Ladies, pick up the big things,
Yeah.
please.
Yeah.
Obviously,
Yeah.
do so wisely, but
Yeah,
yeah.
and get a trainer if you've never done it.
Yep.
But and you need to be doing more and more in order to stress so that you get these micro tears on the bone that then stimulate bone growth. So
There you go.
critical. And then obviously calcium and vitamin D are important as well.
Absolutely. Cool. Okay, so getting back to some hormones. We very like it snuck out of your mouth, but I know that you have more to say out of it about testosterone. So I know that women actually make it, right? But
Hmm.
what's the amount? What should we lean towards? How do we know whether we need it? So,
Yeah.
and then are there certain types that you prefer to use and why?
Yeah, so maybe let me back up and talk about estrogen and
Yeah,
progesterone first. So,
please.
your ovaries are really your main source of estrogen and progesterone. You get a little bit of estrogen from fat cells, but it's a different type. So essentially, when the ovaries shut down, estrogen and progesterone are gone. And we know there's this massive benefit from estrogen for bone health, also probably cardiac and brain health. So, you get the estrogen on board whenever those symptoms of low estrogen start. Progesterone has to be on board if you have a uterus, because if you don't, you're kind of just stimulating growth of the uterine lining. The progesterone kind of balances that out. So if you have an IUD or don't have a uterus, you don't have to take oral progesterone. But if you, otherwise, you should be taking probably oral progesterone, which has its own benefits, like I mentioned, especially with the sleep in perimenopause. So sometimes women who don't need it will take it anyway. So that's estrogen. And then there's also vaginal estradiol, which, because we have so many receptors in that area, often the systemic estrogen is not enough. And so I almost universally prescribe vaginal estradiol. It's like, why not? So those are kind of the three that you want to definitely get on board. And then testosterone is a little bit different. Testosterone in men and women, it's starting in their kind of early to mid 30s, starts to gradually decline. It's not like the cliff with estrogen and progesterone. And there's a lot of debate right now about the kind of whether we need testosterone or not. I mean, we still do make it, so it's not like it disappears. And there is definitely the ability to harm with testosterone. So pellets, where you end up with a very high dose, more like a male dose, can cause lasting changes, male pattern baldness, voice deepening, facial hair that does not go away. So you want to be very judicious with testosterone. It is indicated in women for low libido, but there is some thought that it also helps with bone mass, muscle mass, brain fog. And so sometimes I'll use that in perimenopause, like with just progesterone, and then we add in the estradiol later, or with postmenopausal women if they've got all the things on board and they're still struggling with the libido. And then the formulation, there's various ways to do it. So there's not an FDA approved formulation for women. So I typically will use the men's gel that is a daily dose, and women would use a tenth of that dose a day. That way, you know what you're getting. It just makes it a little messy and hard to measure out. But you can also compound it if people prefer something they just dial up and rub on like a cream. That's perfectly reasonable as well. So that's testosterone. So I think, probably in your community, people are used to thinking of testosterone as like the bodybuilder drug, and we're not using doses like that. And so, if there is an impact on muscle mass, it's probably small, and it probably just has more to do with kind of overall energy level, kind of emotional health that can lead you to perform better physically versus just actual direct effect on the muscle.
So is the gel something that you would apply to like, is it transdermal or is it
Yeah.
into the, okay.
Yep.
All right.
Yeah. It's and you can pull it up into a syringe so you can measure it more accurately, or you can just kind of eyeball it, and you put it on areas where you're unlikely to develop hair growth, because you can get hair growth if you have androgen receptors there. So it's pretty safe if monitored. And so that's the one case where we definitely check a level, because there are women who do have kind of higher than average levels already, and you wouldn't want to add more because you could risk the side effects. And then you want to make sure you're not overshooting with the treatment. So typically checking within about 4 to 6 weeks after starting the hormone treatment.
What could be some potential symptoms that they would notice if the dose is too high?
Yeah. So hair thinning, acne, the acne would probably be the first one because it would just, come up more quickly.
Is there
Chin
any like
hairs.
androgenic
Yeah,
hair? Yeah.
yeah,
Yeah.
yeah. And again, that's irreversible. That you probably don't have any singers in your group, many, but like people,
Maybe.
they will know. Professional singers, it would be really cautioned about testosterone, because you can have a voice change that's not reversible. So
Yeah.
it's definitely the highest risk, I think, of the things that I prescribe. I think estrogen and progesterone seem pretty low risk in comparison, but.
Okay. And then are you mostly doing oral progesterone or is there also a transdermal
Yeah, so
application?
there the bioidentical, and I should also say that, and let's talk about bioidentical for a minute, because I think
Mm.
people get
Yes.
kind of seduced into the compounded formulations because they're personalized and bioidentical. The estradiol that is transdermal is exactly what your body makes, and it's comes from plant sterols, and so but it is the identical molecule, and then FDA approved and regulated, so you know exactly what you're getting. Progesterone, also the oral one, is exactly what your body makes. The molecule itself is too big to be absorbed through the skin. And so you really can't, and you can buy it compounded that way, but you really can't be assured that you're getting enough progesterone to protect your uterus if you're using the transdermal. But if people don't tolerate the oral for a variety of reasons, so it's in peanut oil. So if they have a peanut allergy, you can compound it without the peanut oil, or you can use a synthetic topical progesterone. And then there's also, apparently you can also use the oral pill vaginally. There's just not a lot of great data on it, so you have to kind of monitor as well.
Okay. And when you're saying monitor, is that like testing levels every 3 months?
Yeah, so yeah, the progesterone levels we don't really. It's more just potentially doing a pelvic
Estrogen
ultrasound
based?
periodically. I
Okay.
mean, what you'd worry about is do you have unopposed estrogen for your uterus? And so, whatever form of progesterone you're taking, you want to make sure you're getting essentially the equivalent of that 100 milligram oral tablet a day to your uterus, or that you have an IUD.
Okay. So we've obviously been discussing hormones. What are some other factors that women need to consider from like a longevity perspective? I know you mentioned vitamin D and calcium and doing
Hmm.
your strength training.
Yeah.
Anything else that we're looking at or need to keep our eye on?
I mean, I think those are the big things, the diet and lifestyle, prioritizing sleep. There's all kinds of data about, poor sleep and people who sleep less than a certain number of hours a night, probably five, that they have higher risk of cardiovascular disease. If you snore, making sure you get evaluated for sleep apnea. Sleep apnea is much more common in postmenopausal women than in premenopausal women because something happens with the estrogen. Kind of you get increased laxity in the neck area. So and it's not necessarily so it could even be a serious athlete. It's not the typical male overweight short neck that you see in women, and the symptoms can be different. So if you really are not feeling like you're getting good sleep, getting evaluated for sleep apnea would be critical. And then prediabetes, diabetes is also much more common in the perimenopause, menopause space, even for athletes, I'd say. And so making sure that you're getting routine screening for that and taking measures to decrease insulin resistance if that's something that, we all have different genetic tendencies. And if you happen to be, a little bit more insulin resistant at baseline, even if you're an elite athlete, it can creep up on you. So kind of monitoring that. Same with cholesterol. Certainly not smoking, thinking about alcohol use. I mean, I think we used to say, well, if you're having just a glass a day, it's fine. But the more and more data is coming out showing that there really is there's no physical benefit for alcohol. So there's probably a kind of community, social benefit. But telling yourself that the red wine's helping your heart's probably not
Yeah.
true
Not so
anymore.
much. Not so
Yeah.
much. Yes. I read a fascinating story or a study about the polyphenol content in non alcoholic beer and how it reduced the incidence of colds after a marathon. And they were
Hmm.
drinking like a liter to a liter and a half of non alcoholic beer. So maybe the industry has been pushing these polyphenols like, oh, this red wine polyphenols is so good for you. It's like, but the alcohol's not.
No, no.
So
And I don't know whether the carbs in the low alcohol beer would be either. So I don't,
yeah, you still have some. You still have some.
yeah.
So yeah, speaking of insulin resistance and genetic tendencies and perimenopause, menopause, one of the things that I'm always encouraging, and now it's over the counter, folks to get is if they can bring, and this is a CGM, if they can come at it with a lens of curiosity
Hmm.
instead of like, oh, I feel shame that my blood sugar is spiking. Like, oh my gosh, what am I like? Not panicking, just like stepping back, gathering some data, and then making little tweaks. But it seems like from y'all's end, is that is a hard thing to even if they're creeping up, that is a hard thing to actually get a prescription for. It's like you have to be. So tell me a little bit about
Yeah, I
that.
mean, well, for insurance to cover a CGM, you generally have to be on insulin, like a diabetic on insulin. But you're right. I think that they're like $50 now to do a 2 week. You put
There,
on for two
yeah, it's
weeks.
like a month is $99.
Yeah, and
Yeah.
I think that is totally reasonable. And you don't want to get obsessive about it. I mean, I wouldn't say put one on and never stop, but just, do it periodically and understand how your body's reacting. Because some people can tolerate oatmeal because of the fiber content, and other people, oatmeal sends their blood sugar sky high. So it's just understanding what your unique pattern is and understanding how, if I go for a 10-minute walk after a meal, how much does my sugar drop? And so is that worth kind of investing in? It's just the positive reinforcement and kind of, like you said, understanding your own body. And so I'm a huge fan of that as a just a kind of periodic check-in.
Yeah, love that. Very cool. All right, so if we take everything that we just talked about, which was a lot in a very short amount of time, so thank you. What are the top three takeaways that you would leave people after this episode?
Okay, so first thing I would say is as far as hormone replacement therapy, I've now coming at it from a place of, well, why wouldn't you use hormones? So what are the reasons that you shouldn't versus why should you? Because of the ability to help you kind of live your best life now and prevent bone loss, likely improve your cardiac risk profile, decrease your risk of dementia. So, start with that, but then also, how do you optimize nutrition? And then how do you stay active? And being active is both, cardiac, probably getting in something where you're really getting your heart rate up high to improve your VO2 max. Obviously, the strength training, which we talked about, and then flexibility and balance. So I think that it's sort of a trifecta of, giving yourself what we, evolutionarily would have had probably if we didn't used to die when we were 50.
Mhm.
And then taking care of yourself with the lifestyle issues is what I would say.
That's so awesome. All right. So, Dr. Abby DeVries, how can people get a hold of you?
Yeah, so I am on Facebook and Instagram and TikTok at Sabia Health NC. That's Sabia, as how you spell Sabia. And then on my website is sabiahealthnc.com, and people can sign up for introductory sessions or schedule an appointment or join the membership through there as well.
That's awesome. And you had also mentioned, do we have any homework? Any good books or people you like to
Yes,
follow?
yes,
Or
absolutely.
it's
Yeah.
just like
Yeah.
pulling
So
on your strap.
there's the Menopause is and like I said, a
The
group of female
Menopause.
physicians.
Yes.
Yes, exactly. But my current fan favorite is Kelly Casperson's book, The Menopause Moment.
Okay.
She's a urologist. This is a fantastic book, and she's also hilarious. And then the other one, especially for your group, I would recommend would be Unbreakable by Vonda Wright. And she's an
Okay.
orthopedic surgeon, and she's got a whole exercise program in here as well as nutrition. And then one more would be Heather Hirsch is another very vocal. She's been doing menopause care for about 15 years now, and it's a perimenopause book. So menopause has had a moment. Now we're moving into the perimenopause moment, which is pretty much uncharted territory. It's been great
Yes.
to read about.
Oh, but so great. I love the work that you're doing. Thank you so much for serving the community and for serving us on this podcast. And I mean, that was so much in such a small amount of time. So, Dr. Abby DeVries, thank you so much for coming on the podcast.
Thanks for having me.